Welcome to my YouTube channel. Today we're going to talk about venous thromboembolism in pregnancy. Kindly make sure you subscribe, it will cost you absolutely nothing. So let's begin. We're going to start with the definition of venous thromboembolism in pregnancy, and just from the name, this is venous meaning in vein, and then thromboembolism is the presence of a blood clot, and then in pregnancy. So under venous thromboembolism, we have two. Under the umbrella of venous thromboembolism, we have two common things, and the first one is deep venous thrombosis. And in deep venous thrombosis, this is when you have a presence of a clot in one of the deep veins. And then in pulmonary embolism, this is when you have the presence of a clot in the lungs. So how does pulmonary embolism develop? So already we know that in DVT, we already have the presence of blood clot in the deep veins. And one of the deep veins you can mention maybe is peripheral artery. So when that clot dislodges and then it is now circulating to the blood flow, where will it go? It will travel into the pelvic veins and later find itself into the inferior vena cava and later travel up into the right atrium, right ventricle, and it will be pumped in the pulmonary system and it will dislodge itself in the pulmonary artery, either right or left. So what is the cause of venous thromboembolism? And we have a theory that is the Virchow Triad, and under this theory it is said that we have three factors that contribute to the formation of a clot or development of thrombosis, and one of the factors is hypercoagulability, and hypercoagulability is when the blood has a tendency of forming clots, and one of example is when, for example, you have thrombophilia, that is genetic conditions, or cancer, or for example pregnancy, which is an hypercoagulable state. The next is status. This is when you have abnormalities in blood flow, and endothelial injury. This is when you have damage to the inner lining of the blood vessel, and that this can occur during surgery, can occur during physical trauma, and for example in insertion of intravenous catheters. So we look at the risk factors, and the risk factors, pre-existing factors. So before we start, you can take a ruler and draw the triangle and put the components of the virtual triads. And in each virtual triads, there's now the risk factors for each. So in hypercoagulability, you can have cancer, you can have medical comorbidities, you can have thrombophilias, among and endothelial injury, you can have now trauma, you can have surgery. Under stasis, you can have long travel, you can have a patient who is obese, among other factors. So thrombophilia, medical comorbidities such as cancer, age greater than 5 years, BMI, that is obese patient, parity greater than 3, smoking, and then we have varicose vein. So the next is the obstetric factors. So these are obstetric. For example, in this pregnancy, what do we have? Do we have multiple pregnancy? Do we have preeclampsia? What do we really have? So multiple pregnancy, preeclampsia, cesarean section. So this is a previous cesarean section, prolonged labor. So a patient who comes in with prolonged labor, a patient who has already had stillbirth. Stillbirth, this is when you have intrauterine growth death, intrauterine death, or when this baby is when the person has had preterm birth or postpartum hemorrhage. So in transient factors, these are factors just we shall see them. That is any surgical procedures in pregnancy or puparium, dehydration or hyperemesis. This is when a patient comes in, for example, they have a molar pregnancy and they are really vomiting. Ovarian hyperstimulation syndrome, admission or immobility. That is systemic infection, and then long distance orthostasis. So we're going to do the clinical features. In terms of the clinical features, we're going to begin with DVT, that is deep venous thrombosis. And deep venous thrombosis, it is when you have a blood clot into the veins. So usually it is unilateral. When you find a bilateral DVT, it's very, very, very rare. So therefore you are going to have unilateral leg pain and swelling. And the difference between the swollen leg and the unswollen leg, if it's greater than 2 centimeters, then you highly suspect DVT. So in addition to that, you also have pyrexia and putin edema on the limb. That is pyrexia, you can have warmness of the limb, tenderness and prominence of the superficial veins. And usually in pregnancy, the proximal veins are usually mostly or commonly affected or involved. In addition to that, the left leg is most commonly affected due to the compression effect of the uterus on the left iliac vein. So the uterus most commonly compresses the left iliac vein, causing stasis. And what did we say the etiology of venous thromboembolism are? Hypercoagulability, stasis, and endothelial injury. So pulmonary embolism, the clinical features. First of all, just to remind you what's pulmonary embolism. This is when you have clots into the pulmonary arteries in the lungs. So how does that clot reach? And most commonly, it originates from the DVT. And DVT, we say this is the formation of blood clots in the deep veins. So when that blood clot dislodges, then it travels up from the legs to the pelvis, to the inferior vena cava, to the right ventricle, to the right atrium, to the right ventricle, and then it's pumped out into the pulmonary system. Then there it can then there it can block or be found into the pulmonary arteries. So how is the patient going to present? So most commonly, the patient may be actually asymptomatic, but they may sometimes present with symptoms, and the symptoms that they present with is sudden onset of dyspnea, that is shortness of breath. They may also present with pleuritic chest pain. They may come in with chest pains. They may also present in with cough or hemoptysis at rare cases. And clinically, if this patient has a massive PE, then they usually present in with tachycardia, that is increased heart rate, tachypnea, increased breathing rate, pyrexia, that is fever, and raised GVP, pulmonary rub, and pleural effusion at rare cases. It is important to always examine any signs of DVT in a patient with suspected PE, because we say the most common source of the clot, this clot is usually DVT. So what are the differential diagnoses in a patient who comes in with DVT? First of all, the first common differential diagnosis is cellulitis, and this one is usually an infection, ruptured Becker cyst, superficial vein thrombolytis. And in a patient who comes in with PE, what are you going to suspect? They have come in with shortness of breath, they have come in with cough, they have come in with pleuritic chest pain. What are you going to suspect? You're going to suspect acute coronary symptoms because of the chest pains. Aortic dissection. Which way will the pain be referred to? Back. The pain will usually refer at the back, and then the patient can come in with pneumonia or pneumothorax. That is the differential diagnosis. So we're going now to go to management or treatment of venous thromboembolism in pregnancy. And what's our main problem? Our main problem is formation of blood clots. So the medications that we're going to give are going to prevent formation of these blood clots. So which medications are we going to give? We are going to give anticoagulants. So we are going to discuss briefly the classes of anticoagulants. And the classes of anticoagulants we have indirect thrombin inhibitors, we have direct thrombin inhibitors, and then we have vitamin K antagonist. So in terms of indirect thrombin inhibitors, we have the heparins. And in terms of the heparins, we have unfractionated heparin. We have low molecular weight heparin, that is enoxaparin as an example. We have synthetic heparins, that is a synthetic heparin pentasaccharide, that is fontaparinax. And then now those are the heparins. And then lastly, under indirect thrombin inhibitors, we have the new oral administered factor 10A inhibitors, and examples we have rivaroxaban, apixaban, and endoxaban. So these ones are not given in pregnancies. So direct thrombin inhibitors, we have agabatron, we have lepirudin, we have bivalidrin, and then we have dabigatran. And so in direct thrombin inhibitors, the first three are IV medications, and then the last one is oral. In indirect thrombin inhibitors, all of these are IV medications, and then or subcutaneous medication, and then the new oral administered obvious oral, meaning it's an oral drug. And lastly, we have vitamin K antagonist, which is warfarin, which is totally contraindicated in pregnancy. And the reason behind this, you're going to see in the next few slides. So now let's look at the investigations. And the investigation, you're going to begin with basics. Basics in terms of you do a full blood count, you do a UEC, that is a urea electrolytes, and you do LFT. This is even before anything. Basics, these are able to tell us, for example, if we do a fluid blood count, do we have elevated WBCs? Do we have elevated or low platelets? Do we have how is our blood? How is our blood? So if already so this is just going to tell us if you already have elevated WBC, it's most going to indicate what infections. Then UECs. This is very important because most of the drugs that we are going to give in terms of anticoagulants are excreted by the liver, sorry, the kidney. And examples of these drugs include low molecular heparin and what? Synthetics heparin. And then LFTs, because these drugs that you're going to give are going to be metabolized by the liver. So we have to check how is our liver doing. And even one of the drugs is going to be excreted by the liver. Which drug? Unfractionated heparin. And that's why we give unfractionated heparin in patients who come in with problems with the kidneys. Understood? Yes. So you also do a coagulation screen, for example, ANR, APTT, all those. Then the next thing you're going to do is D-dimer. D-dimer in this case, during pregnancy, the D-dimer is usually elevated. So at this case, D-dimer does not have significance compared to a patient who is not pregnant. So even if you do D-dimer, it will not be of significant value. It will not give you a significant or it's not of value. So we don't advocate you doing for D-dimer, just facing the patient's mind. However, you do if a patient comes in with a DVT, what you do, the first thing you do, for DVT, you do compression duplex ultrasound. It should be venous compression duplex ultrasound. And in this, if it is positive, then you start anticoagulation. If it is negative, but you really think that this patient clinical suspicion is high, then what you do is you repeat after 1 week. While just as you are waiting that 1 week, this patient must be on anticoagulation. Kindly note that the biggest weapon you have as a clinician is your clinical skills. Clinical skills. Those are your biggest skills or weapons. For PE, for definitive diagnosis, the definitive diagnosis of DVT is venous complex duplex ultrasound. For PE, you do an ECG. The patient comes in with what are our differentials? For example, acute coronary diseases. So the patient comes in with pleuritic chest pain, comes in with shortness of breath. You do an ECG, you do a chest X-ray. This is to rule in and rule out differential diagnosis. For example, a pneumonia, which you can get in chest X-ray. An ECG is very indicative even of the PE and even of the acute coronary syndromes. In addition to that, you do arterial blood curves, and the definitive diagnosis is CTPA, and this one is what is usually advised at most cases. However, you can also do a VQ scan, and what they say these are the definitive diagnoses. But make sure CTPA is in your hands for diagnosis of PE, and for diagnosis of DVT, what is in yours? Venous compression duplex ultrasound. So clinical parts in terms of management, so we are going to management. I already talked about the classes of anticoagulants. So in terms of management, our preferred drug for management is heparin, and to be specific, low molecular heparin. However, in certain cases, for example, we don't have that low molecular heparin, or the cost of low molecular heparin is actually very high. So most patients will prefer, or doctors, or now after you have been advised, you can be given unfractionated heparin. And in most cases, even in developing countries, they cannot afford the low molecular heparin, they cannot afford the unfractionated heparin. So what do you do in that kind of case? So what you do, the first thing is you put, regardless whether you have money or not, you put the patient in the first trimester on heparin till 14 weeks. The reason behind this, because the cheap medication we have as anticoagulant is warfarin. In terms of warfarin, it is teratogenic, especially in first trimester. And in that trimester, it usually causes fetal hemorrhage. So, as a clinician, we don't advocate giving of warfarin in first trimester and in that trimester. So, if you have to give it for whatever reason, then you don't give it in first trimester and in that trimester. So, from 14 weeks to 36 weeks, then you put the patient on warfarin on 5 mg OD, and then your target ANR is 2 to 3. Are we okay up to there? And then now, because you said in that trimester, it predisposes the fetal, because warfarin usually crosses the placenta. and usually predisposes the fetus for fetal hemorrhage, then or fetal bleeding. From 36 weeks, you put back on heparin, and then on delivery you withhold the heparin for 24 hours. This is to prevent things like, because in delivery it can either be cesarean section or normal delivery, to prevent bleeding. So after delivery is then the patient was on warfarin because of maybe contradictions of heparin or because of financial constraint. Then you put the patient back on heparin and you give the heparin for 6 to 12 weeks postpartum. But if your patient has money and they can afford heparin, whichever heparin you put, heparin from the time you have diagnosed DVT or PE to upon delivery, then you withhold for 24 hours, and then postpartum you continue on heparin. Thank you. Kindly subscribe. It will cost you absolutely